Thank you very much, Hans, for the introduction, and thank you very much for the welcome by Dr. Chalabi. I'm very happy to be able to welcome you all for this conference on this very narrow and to some maybe even nerded area. Only the suprainguinal groin problems, only the sports hernia, whatever we end up calling it. It is a very important and intriguing problem that we're talking about today. And I will always, of course, thank our especially international speakers for accepting our invitation and joining us here. The patient we're talking about, well, very often when they come to our office, they look the same, so to say. They are physically active, they can be young, they can be middle-aged, they may have a trauma, they may only say that it's something that just gradually developed, maybe some overuse problem. Their complaints are often the same, more or less. They have pain when they do running, especially fast running, fast turns, sprinting, when they're on a slippery surface, when they have to change direction, kicking, tackling. If they do long runs and they get tired, then they might have some of the problems even more prominent. Coughing and sneezing, often a complaint when they are suffering the most. And then these standing on one leg, balancing, putting on socks kind of activity that a lot of the players can describe to you that this is characteristic, this is where I really feel the problem in my everyday life. We know from a number of studies that there are multiple causes of groin pain, not only between patients, but also within the same patient. We have been working with these problems for many years, and we have proposed a set of clinical entities that sort of describes the various symptoms and clinical findings related to specific anatomical structures. And looking at it that way, we try to sort of relate the symptoms and the problems that the athletes have to specific anatomical regions, as we in many cases not yet know precisely what is the diagnosis, what is actually the etiology of the individual problems. So what is a sportsman's hernia? And I'm quoting this from a piece of literature. I'm not putting on who it was, because a condition that can successfully be treated by herniaplasty, well, is that a diagnosis? Is that a definition? It's very, very problematic, but it's sometimes a feeling they get that, we don't really know, but let's do a hernia operation for this. Let's do a sports hernia operation and see, and if it worked, then this was what was wrong with the patient. If it doesn't work, then we'll have to do something else, and of course we all agree that this is not a good approach. The player that come to us with groin pain, well, maybe we could put them into some of the clinical entities I mentioned before. They could have adductor-related, hip flexor-related, hip joint-related problems, but some of them still have some other problem. We treat them, we do exercises and stuff. We do our general groin treatment programs, but they still have, some of them, pain a little more proximal in the groin area, and they do not respond with that complaint with any of the other treatments we're giving them. So we have a problem. And why are these patients still a major problem? Well, I think the main thing, and I hope that we'll get a little closer today and tomorrow, is that we have no consensus on definitions. What is this problem actually about? And we have no clear diagnosis. I'm sure that all our distinguished speakers, surgeons, they have their diagnosis and their definitions. But I guess if we could round up all of them in here and compare, we would have quite a wide range of definitions, and we need to, within the coming years, get this narrowed down to something that is much more precise and much more scientific. So I hope this will be one of the things we can achieve here. And before we have that, it's very difficult to have a lot of discussions what is actually the etiology, as we don't know what it is we're looking for etiology of. And how should we treat something that we haven't really defined and have clear diagnosis on. But that's what we're going to do. today and tomorrow. We're of course going to discuss this on the level we are now, but hopefully within the coming years we'll get much closer to the, so to say, real thing. Adam just beautifully illustrated the anatomy, so I'm not going into details with that, just mentioning that there's no doubt that this common anatomical and functional unit with the rectus abdominis, the adductors, the oblique abdominal muscles, and the symphysis joint has a large importance in this, and we have to relate to it, and hopefully it will give us, it will all help us to get closer to explanations and to finally define and describe this problem. So the history, the classical way, of course, any previous groin problems in the family, any long line of hernia surgery that could perhaps predispose also to this kind of problems. Did you have previous groin or hip pain? Was it the same, difference? What kind of treatment did you get? Did you have any kind of surgery before in the groin, in the hip region? Did you have other long-standing painful conditions? We know that some of these patients have difficulties coping with pain, have difficulties responding in a what we believe is a natural way to what we're doing and the pain they have. So having previous problems with long-standing painful conditions could also give us a point in maybe a different direction. And then, of course, is there any gastrointestinal problems? Is there any urogenital problems? We should be aware of that. And then I put on weight loss just to remember all of us that even these young athletes, active people we see, could have diseases that were more serious, cancer, other things that we have to think of, even though they are playing football 5 times a week. We ask about how did it all start? Was there trauma involved? Was it overuse? Did it come gradually? What kind of pain do they have? What is the character of the pain? Is it radiating? Do they feel it comes from somewhere else? Or does it radiate to something else? Is it a constant or intermittent pain? The location, is it exactly the same spot? Is it just this 1 square centimeter every time? Or is it growing? Is it changing a little bit? Sometimes the patients say that the pain is moving. First it was on the right side, now it's on the left side, and now it's gone down there like it was some animal running around. And you have to sort of see where they're going in that direction. And physical activity, is it correlated to that? Is it specific activities? And what can they do to prevent the pain? Could they do specific activities? And they say, well, this eases the pain. So you're putting all this history together, and then you start to get a picture in your head. A lot of the patients, in my experience, complain of pain, low abdominal in the area of the inguinal canal, often radiating across the pubis or radiating to the groin and maybe also to the genitals. They have problems with activities including abdominal muscles and pain during fast turns, sprinting, etc., as I mentioned before, is characteristic for these kind of patients. Of course, classic hernia symptom that we all learn in medical school, coughing and sneezing, also goes for this group, but as they also do for the adductor-related patients, the hip flexor-related patients. So it's difficult to pinpoint it as a very specific complaint. The clinical findings that, and I'm just putting up to you now the way that I do it, and I'm sure that the surgeons we're going to hear later on will give you their more specific ways of doing it. This is the way I look at it. And I mentioned the conjoined tendon. I just learned that it doesn't exist. Well, hopefully some of the surgeons will support me a little bit. But I would say that, of course, what I actually go for is the pubic tubercle. And the way we do it is that we find the inguinal ligament, and just medial to the inguinal ligament on this bony bump there, which is the pubic tubercle, just medial to that, and the 1 and 2 centimeters proximal to that is the area where I often find that the patient is very tender. If I do scrotal palpation, I do it with the patient standing, and instead of or after putting my finger to the inguinal canal, I put it in front of the inguinal canal and then goes up from sort of inside to palpate the area of the pubic tubercle. And very often it's, of course, uncomfortable, but it's much more painful on the injured side than on the other side. Also, I palpate the external opening of the inguinal canal, and as I said, I do it with the patient standing, compared to the other side, of course. And what we find in most cases where we believe that this is an entity is that it's uncomfortable, a little more than on the other side, sometimes painful, especially if they have been doing physical activity the same day or in the recent couple of days. Often I tell myself that I can palpate a soft spot, like I feel that especially in it will be lateral inferior corner of the opening, that there's a soft spot there, maybe a soft, weak posterior wall. We test abdominals as well, both oblique and the rectus abdominis, and sometimes this also reproduces the pain that the patient knows. On imaging, I'm going to leave that to Dr. Reed in a moment, but what we do in our clinic is that we do a standard X-ray of the pelvis with the patient standing, AP with 15 degrees of internal rotation, and we do a true lateral hip with 15 degrees of internal rotation. This is one of the reasons we do it on all our patients. We don't want to miss terrible stuff like that. We do a general ultrasound examination of the area, and then we of course include a dynamic evaluation, which is part of our definition of the entity. We also have a number of nerves in this area, and you can sometimes have patients with nerve entrapments, and with patients who have a bit more diffuse description of where the pain is, who have radiating pain, who have more nerve-like complaints, then it is very important also to examine for that. And in very rare cases, we find a nerve entrapment, and you can do surgical release of that, either by cutting the nerve, small cutaneous nerves usually, or releasing and making room for it. So I took a look at the literature, and I'm not going to do a lot of talk on how and what this is, but if you look and sort of read the past 10 years of papers, you get this, you could maybe sum it up like this. Say that there's a weakness of the posterior wall of the inguinal canal. This, with continuing activity sport, can lead to a dilation of the transversalis fascia at its weakest point. The inguinal triangle becomes wider. There comes increased tension on the stabilizing tendons, muscles. Things are giving pressure, pulling, and this compression can give rise to pain, and in some situations also to compression and irritation of the genitofemoral nerve. But where does this weakness come from? Why are they weak? Well, there could be some genetical stuff, as I mentioned earlier, but 30–40%, if you look at the reports of the studies that are out there, would report some sort of trauma to the onset of groin injury. So there might be a lesion of these oblique muscles, maybe. Partial tear, maybe a hard stress on the muscle, and it becomes a bit weaker. It loses some tension, and gradually things are weaker there. And as you keep on pressing and you keep on using your abdominal muscles, then you stress them, and gradually this could develop. So some sort of trauma, or maybe just some sort of unbalanced muscle strength, stronger, too strong in one side compared to the other, or too weak actually, which is probably more the problem. Or maybe we have some problem with decreased range of motion. There's conflicting evidence pointing in different directions when you look at the range of motion and the connection to groin injury. And maybe it is because the various ways we're measuring this range of motion. And are we measuring tendon and muscle length? Are we measuring capsular tightness of the hip joint? Or is it the bony constraints? And this, of course, leads me up to, I have to talk a little bit about the hip impingement as well. Because femoral acetabular impingement with the cam deformity that some have, this is the normal, and this is the situation where you have excess bony growth at the between the femoral head and the femoral neck, and this can give rise to problem in the hip joint with labral or cartilage lesions, but it can also maybe give rise to decreased range of motion, not necessarily leading to a hip joint problem itself, but a decreased range of motion. And the other side of it, the pincer side, where you have problems with too deep an acetabulum, or you have an irregular acetabulum where it has a sort of an overgrowth, and then you have a collision between the femoral neck and the labrum here. And this, again, can lead to joint problems, but it can also lead to decreased range of motion. And it has been suggested in the literature recently, as we have done some years ago, that there might be a connection between decreased range of motion, maybe on the basis of FAI. Because if you have decreased flexion and internal rotation, as you often see in these patients, even though they have no hip joint symptoms apart from this decreased range of motion, then for an athlete to play football, to run, kick, jump, this lack of flexion might give rise to some overuse. Because you have to substitute this range of motion by other movements. And these movements, they will need other muscles, other structures to be used, maybe overused. And in that way, you will increase stress to these structures. It could be the pubic bone, the symphysis joint, the SI joints, the low back, the adductor anasthesis, iliopsoas muscle, or the oblique muscles of the abdominals. So something is pointing, and Chris Larson last year published a nice case series indicating that there was a connection between patients with FAI problems and with sports hernias, incipient hernias, whatever. So to diagnose these patients properly, I think one of the things we have to do as well is to be able to diagnose FAI. So we have to know the impingement test, how it's done. We have to know the apprehension test, for instance, and maybe also the posterior impingement test. These are tests that indicate whether there is problems, pain, and of course also will tell us about the decreased range of motion. We also have to be able to identify if there's a psoas problem in these patients. The psoas is a very, very important muscle, and I think this is going to be a focus area in the coming years for the Sports Groin Pain Center to look at the psoas as well, because it's a very big, important muscle to all of the activities that we are looking at here. You can palpate the psoas. You can palpate it at the level of the anterior iliac spine here. You can palpate it deep here, and you can palpate it under the ligament, just lateral to the sartorius muscle, medial to the vessels. There the muscle is subcutaneously. You can also use the Thomas test and see if there's any tightness of the muscle, and you can do stretching to see whether this gives rise to some of the pain that the patient knows, and that can be part of the pain problem that sort of is overlapping with the groin problems. We use the isometric test, and we do it in the inner range, 90, 100, 110 degrees, where the iliopsoas complex is the most important hip flexor. And we should remember, again, when we do the impingement test, that when we do that, we also compress the psoas. We are doing flexion, adduction, internal rotation. Of course, we're squeezing the psoas as we're squeezing lots of other structures there. So it's very important to differentiate these things and be able to take one from the other. The adductors, we do a test like this. Adduction against resistance. Are they strong? Are they weak? And also, is it painful to when we do this? And the pain that they have, is it pain that they know? Is it reproducing the pain that is their main complaint? We palpate the adductor origin, the adductor longus mainly, which is easy to find, but of course we're palpating both the adductor longus and the gracilis, and right behind these two structures, as Adam showed us a moment ago, we have the adductor brevis as well, and we follow it all the way up to the enthesis and to the aponeurosis on the pubic bone. We also change range of motion, and if there's any pain, stretching the adductors. So we have a lot of differential diagnoses that are very important to all of us to know when we want to treat these patients. If you're a hip surgeon doing hip arthroscopies, you shouldn't only be able to do a hip impingement test and look at x-rays. You should also be able to differentiate and maybe to realize that this patient might have some x-ray changes, but also some soft tissue problems that should be treated and maybe will take away your operation indication. And it's the same for the abdominal surgeon who wants to do the sports hernia surgery. It's the same for the sports physician and physiotherapist who wants to treat the soft tissue problems, that you should be able to recognize if there is a surgical problem here from a sports hernia situation or from a hip joint. So when we treat this, it's important that I don't think that it's realistic that we in all situations involve 3 or 4 specialists every time we have a patient. So you have to learn these examination techniques and you have to be aware of it and be able to distinguish. And then if you're in doubt, then of course you can send it or use experts in this situation from other specialties or other regions of your specialty. Treatment options, well, medicine, pharmacological, we can give them pills, we can give them various things, and there's nothing in the literature showing us that this is good. Passive ways of treatment, old types of electrical stimulation and stuff like that, probably not what we're looking for. So what we're discussing today and tomorrow will be the 2 options, surgery and exercise therapy, and I'm really looking forward to our discussions. Thank you very much.